All right. Good morning, everyone, and welcome to the second day of this public meeting of the Physician-Focused Payment Technical Advisory Committee, or PTAC. We began our work yesterday with remarks from the Secretary, CMS Administrator, and CMMI Director. The physician community has responded impressively to the opportunity for creating physician-focused payment models that Congress established under MACRA. Over the past 2 years, PTAC fully reviewed 18 proposals and recommended 10 of these models to the Secretary of HHS to test or implement. The members of PTAC and many members of the stakeholder community have been disappointed that none of these models are being actively tested. We believe that significant savings could be achieved for the Medicare program and that care could be improved for a large number of beneficiaries by implementing the payment models that PTAC has recommended so far. We are encouraged by the comments made yesterday by Secretary Azar, Administrator Verma, and Deputy Administrator Bowler. They acknowledged that more alternative payment models are needed. Clearly, the payment models that we have recommended are consistent with the vision and priorities for value-based health care they described. We are pleased to hear that the Innovation Center is working actively and aggressively on several models based on the recommendations PTAC has made. We feel strongly that in order for these models to succeed, refinements in the models and planning for implementation must be done in close collaboration with the physician practices and organizations that propose them. We fear that stakeholders will not continue to participate in the PTAC process unless rapid progress is made in implementing the models they have proposed and we have recommended. Based on the comments made yesterday, we foresee hearing from both stakeholders and CMMI over the next several months that they're actively working together to finalize the designs of these models and that a plan for implementation of one or more models will be announced by the end of 2018. We'll report on the status of implementation at our December meeting. What I would like to do, starting with Dr. Ferris, is I would just like to go around to each committee member and ask if they concur with the statement.
I concur.
I concur.
I concur with the statement you made.
I concur.
I concur.
I concur.
I concur.
And I concur.
I concur.
Thank you. So now we're going to continue with our agenda. Today we will review the proposal submitted by the University of Chicago Medicine called the Comprehensive Care Physician Payment Model, also known as the CCP-PM. In addition, after we conclude our deliberations, there'll be an opportunity for stakeholders to make public comments on PTAC's processes. To begin with, we'll go around the room and introduce ourselves and declare any potential conflicts of interest. I'll start with myself, Dr. Jeffrey Baylett. I'm the Executive Vice President of Blue Shield of California for Healthcare Quality and Affordability, and I have no conflicts to declare. Rhonda?
I'm Dr. Rhonda Meadows, President, Population Health Management at Providence St. Joseph Health. I have no conflicts, no disclosures.
My name is Bob Berenson. I'm an Institute Fellow at the Urban Institute. I want to disclose that a couple of years ago I participated on a panel with David Meltzer at a National Health Policy Forum. He presented the results of his HICIA project supported by an accompanying Health Affairs article that presented the concept, and I remember correctly some initial findings from that HICIA award. I commented that the model seemed to fill an important void in the primary care delivery related to care for sick patients and sounded promising. That's it. I've had no contact with Dr. Meltzer or the University of Chicago since then.
Okay.
That's impressive. I'm amazed you remembered your comments.
That's what I
No, I read it.
Kavita Patel, a primary care physician at Johns Hopkins and a fellow at the Brookings Institution. I have no conflicts.
Lynn Nichols, I direct the Center for Health Policy Research and Ethics at George Mason University, and I know and like David Meltzer, but I have no conflict.
Bruce Steinwald, health economist here in Washington, D.C. I have no conflicts.
Paul Casal, cardiologist and executive director of New York Quality Care, the ACO for New York Presbyterian, Weill Cornell, and Columbia. I have no conflicts.
Good morning, Harold Miller, CEO of the Center for Healthcare Quality and Payment Reform. I have no conflicts or disclosures.
Good morning. I'm Grace Terrell. I'm a practicing general internist at Wake Forest Baptist Health and the Chief Executive Officer of Envision Genomics, a board member and founder of CHESS, a population health management company, and I have no conflicts.
I'm Tim Ferris, a primary care physician and CEO of the Physicians Organization at Mass General Hospital. I'm on the board of Health Catalyst, a data analytics company, and the board of the National Health Service of England. Thank you. No conflicts or disclosures.
Thank you. I'm going to go ahead and turn it over to our,
To me.
right.
All right.
No, yeah, that's fine. Please, go ahead, Kavita. Dr. Patel.
I was going to say, which one of us? Yeah, we had it was myself and Paul and Tim, so we had probably 3 people uniquely for a PRT that have actually served in many of the care delivery roles described by this model. So if the chair will allow, I think the 3 of us on the PRT, there was so much that we just couldn't put into PowerPoint slides, so I'm just going to try to encapsulate and then go ahead and move through our slides fairly quickly so that we can spend some time with the submitter themselves to talk about this. I'm going to go through the usual formality and get to kind of the proposal. What I wanted to do a little off script for the 3 of us, not speaking for Paul and Tim, but it's so clear that when we got this proposal, it addressed such an important clinical problem. And just as a sidebar, I was just teasing Bob because I just reviewed his Annals of Internal Medicine article that he wrote with Eric Coleman from 15 years ago about transitions of care in hospital medicine, and how that's been one of the few areas where some of the prescriptions made in 2003 or 4 have come to fruition. For example, bundling of episodes, having some things in the fee schedule that directly address transitions. But as the PRT came to this proposal, we were still faced with such an important clinical area that I think that the CCP at its heart, if you think about it, it's called a comprehensive care physician. So those of us who, all 3 of us know Dr. Meltzer kind of by reputation and scholarly achievement, this is really trying to pioneer a way of thinking about medicine that we desperately need. And so we came to this trying to think about an important clinical care concept that is transitions in care, but then kind of aligning this with the elements of a physician payment model. And so hopefully what you see in our proposal overview is this equipoise of struggle with thinking through methodological issues, some of the permutations of putting a payment model on top of a very important clinical care issue, and how do we then bring that forward. And at its heart, the proposal, you'll see a couple of things in our slides. I'm just going to highlight the core elements. And those of you who are familiar with the CCP model, whether it's in some of the trade publications, New York Times, Popular Press, Health Affairs article that Bob referenced, as well as the HHS Award, you can look to various sources, but at its heart, it's a mechanism to take care of patients who are identified for being at risk for either rehospitalization or at risk for complications upon discharge from hospitalization. It's important to remember that kind of the essential trigger or qualifying criteria is one hospitalization in the last year, but as the submitters will tell you, there's some flexibility around considering that criteria. But the other strength of this has been, in their HHS Award, is the use of a very elegant randomized controlled trial design in order to carry out something that Tim referenced yesterday, a little bit of beta testing. So this is a HHS Award RCT trial evaluation results that are highlighted in our full proposal, in the full PTAC packet, but the actual payment model that goes with it, and I'll forward to that, is around participating physicians usually usually inpatient physicians, but could also be from the outpatient setting, taking care of someone who has been hospitalized in the last year to receive monthly fees. And there are both kind of penalties and rewards in the amount of those monthly fees for keeping up with current standards of care. Another note that the PRT wants to acknowledge, we'll get into individual criterion, is that unlike some of the other payment models that we've seen before that tend to be a little bit more standalone, a feature of this payment model that's proposed is that it could actually be nested easily within other models, offering some flexibility for existing alternative payment models, but as you'll see from some of our comments, that can pose some challenges as well. So it might just be we tried to put a graphic to this, but it was a little difficult, so we just put it into these boxes to illustrate what the dollars and how the payment would align for a patient and physician participating in this model. There's a $40 per month fee for a new or renewed patient, and that's a care continuity fee, a $10 for kind of currently continued enrolled patients per month, and those are payable at the end of the year, again, with some flexibility if there needs to be other intermittent payment periods for reasons that CMS might identify. And the kicker here is on the right, and I would say that for us, it was important to understand the difference between the care continuity fee criteria that you must meet in order to receive these monthly fees. That's in the top right box, meaning, and just bear with me, in order to continue to receive these fees, you have to meet both criteria of a threshold of inpatient care for your panel of enrolled patients that exceeds 50%, and the provision of your outpatient general medical care for your panel of enrolled patients exceeds 67%. So what you see is really trying to put into place kind of threshold and proportional amounts, which would translate to having any sort of internist, family physician. There's flexibility. It could be a specialist that does this, provide both inpatient and outpatient care. And clearly from the percentages, they're trying to offer that in this model, you wouldn't do too much of one or too little of the other. Now those are the two criteria in order to receive these fees. And then there are penalty criteria where there are additional fines, and the penalty fines that were proposed were $10 per patient per month, which are also payable at the end of each year if either of the penalty criterion occur. So again, bear with us. The penalty criterion is just one of these, unlike the payment criterion where you have to meet both. If one of these were to occur, you trigger kind of an incidental payment penalty, percent provision of inpatient care that falls below 25%, or percent provision of outpatient care that falls below 33%. So you can see how they're highly complementary, obviously, the penalty and payment criteria, but it's important to designate that there was an implicit assumption about the proportions of which amounts would qualify for both the payment as well as what would qualify for someone who was penalized. And something that we also had to kind of spend some time with the proposal. In the proposal, everything refers to an enrolled panel of patients. There is not an assumption that any physician participating in this would have their entire kind of physician panel of these patients, but there have been some suggested amounts for caps potentially within a typical panel of patients, such that the entire panel, my panel, Tim's panel, Paul's panel, would not necessarily all be CCP patients. And again, that reflects the fact that not every single patient in one of a person's typical panels or hospitalist panels would actually be a high-risk patient. So that's a little bit of an overview. And so again, remember kind of the clinical care model that's being proposed is one that's triggered by an inpatient hospitalization, and the goal really is for continuity of care. And for illustrative purposes, it helped us to just understand what would this look like in real life. So a little bit off script again, if the chair doesn't mind, but you would imagine that as a patient who is identified either in the outpatient or inpatient setting would actually be the candidate for the CCP program. There's a set of enrollment criteria and kind of patient consent that's actually been pretty robustly tested in their randomized controlled trial, and that would trigger basically a hospitalist or another type of physician then assuming the care for that patient on a longitudinal basis. And if that patient has a pre-existing relationship with other specialists or other doctors, that CCP physician would kind of play the role of quarterback and help coordinate the care for all those other physicians. But we did bring up in our PRT discussion some tensions that could occur if there are already longstanding relationships, particularly in community-based settings, that might not be as highly integrated, and what would that communication look like? And again, these penalty and payment criteria would apply for that CCP physician. And you could imagine if that CCP physician is an internist that's a hospitalist, they would actually physically be seeing these patients potentially in an outpatient setting or some sort of clinic office-based setting for some of those subsequent visits after a hospital discharge, and vice versa. A community-based outpatient physician might be coming into the hospital to help do part of a discharge visit. So in a way, the PRT kind of commented that this brings us back to a model of medicine that we actually, some of us actually started training in and did for a number of years until we started moving into a little bit more siloed models. You'll see from, all of you have our packet, and you'll see that we did have some unanimity around several of our criteria, particularly an overall sentiment that there was this tension between the clinical model and then actually the criterion for the PFPM, and particularly the high priority criterion. I want to underscore that the discussion was pretty rich, and you'll see that there were several instances where we did not reach unanimity, and in particular the scope criterion. So I do want to just kind of highlight what I felt like were the key issues and then have my colleagues add in. It's incredibly, and I think that for us, this issue between where does outpatient care kind of start, where does inpatient care, kind of end, is incredibly difficult for complex patients that are described in the CCP model. So what we know, and as I referenced this 2004 article that Bob wrote, we know that the needs of these patients, despite advances, are still not being met. However, we think that what we're trying to struggle with is, do we have enough assurance in the proposed payment model that by just simply replicating this very rigorous, kind of RCT-based, high-quality clinical standard, will we find the same kind of replicability across other settings? And then because of some of the findings in the HHCA evaluation, and I'll just highlight several, one, that it did not show significant savings, and then two, that there were actually a slight increase in emergency department visits, we wanted to make sure that there were sufficient quality measures as well as potentially other areas that could be added for accountability so that the financial model could be applied more broadly. I want to make sure I'm going on the right slide. And we highlighted at the last bullet point there is that you'll see that one of the questions we ask are the workflows and career paths, what I described to you about this kind of throwback almost to when internists like myself went in and out of hospitals much more fluidly, is this actually something that's likely to be adopted outside of a highly integrated setting or even within an integrated setting? And then could there be other ways to do this that actually address the important clinical challenges? The next slide, I mentioned already some of the HCCA issues. I do want to just cite that the qualitative findings done in focus groups, although limited because there were smaller numbers, were so strong for the patient's kind of positive sentiments about being in this model. And then the provider satisfaction, which has been shown in several studies that are in your PRT packet, are pretty compelling for satisfaction of the providers who participate in this model, understanding, again, this is all voluntary, which is what the submitter would propose. That we did feel like there were some pretty significant issues around this possibility of discontinuity if a primary care physician kind of stopped following a patient that was enrolled in CCP, and then potentially vice versa. And so it almost felt like, how could we avoid the inevitable delay of that transition that has to occur at some point? And then we also wanted to understand a little bit more about how to match the kind of qualitative findings that I highlighted with some of the lack of quantitative findings, not just from the HICIA evaluation, but some of the concerns around achievability of savings, as well as a positive result in clinical outcomes. So for that scope, high priority, which we had a majority opinion that it did not meet, we were not, and we had a lot of discussion, so that I will just try to say that between the potential for a limited feasibility, which might just be, this might really not apply outside of highly integrated or even academic settings, as well as kind of how little we knew about the potential to lower the cost of care. There are estimates within the proposal of the potential for savings in Medicare, but there might be other ways to more directly achieve those savings. And in particular, the strength of this proposal, which is that it could be within an ACO or in a bundled payment program, brought up the fact that those programs as standalone programs already have in place inherent financial and clinical incentives to lower cost of care. So is this really adding to the opportunity for participation in an APM, or are we simply putting more into what's already existing and not necessarily expanding scope? So those are a little bit of the highlights for where we had a very robust back and forth. We did not achieve unanimity on this, but we felt it did not pass that criterion. For quality and cost, we all felt that it did not meet this criterion, and this again was from this opacity related to what savings were estimated on the cost side, as well as kind of very concrete and tangible quality measures for tracking and comparison to peers. Now, one would say, and the submitter should have an opportunity to weigh in, we looked very carefully at this proportional threshold issue and had a conversation about what those thresholds inherently represent, quality metrics, if you will, because you have to, in order to get money or in order to avoid paying a penalty, you have to meet these thresholds. So we did not feel that the submitter had zero quality measures. However, it isn't clear if those thresholds correlate to individual or population-based quality measures. And while we respected the fact that the submitter did not want to necessarily do what is pretty common in hospital-based medicine and in outpatient-based medicine, which is to have this long laundry list of quality measures, many of which do not apply to your particular patient. So we wanted to applaud the strength of being flexible. We still felt like it was very difficult to actually tackle the central question in this criterion, that we could say that this payment model would improve healthcare quality. So I'm saying these things because you can only imagine how difficult it was for us to try to wrestle with what in concept would seem to indicate high quality, that is a physician who's balancing their outpatient and inpatient load proportionally and has kind of robust experience in both. And yet we still felt like there was a lack of some of these metrics. And then just as a final note, the patient empanelment part as part of a randomized clinical trial in the HICIA award was pretty clearly delineated. If you even go on the CCP website at the University of Chicago, you'll see very clear criteria that are patient-facing for participating in this program. But in their proposal, we felt like it was not entirely clear how robust patient empanelment could be implemented to avoid adverse risk selection, and that was something that we also wrestled with in that criterion. And then the third high priority payment methodology criterion, another one where we had a unanimous opinion that it did not meet the criterion. There's a very obvious, from that slide I showed you with the boxes, there's a clear payment mechanism here. So it's actually pretty easy, unlike some of the other payment models that we're all experienced with, to understand what the outlays, kind of the outlays and the fiscal spending might be based on your own institution or your own practice's past admission patterns. And we acknowledge that this could be standalone, nested within another alternative payment model. But at the end of the day, as something that we felt like could be an opportunity for improvement would be a way to actually improve, and sometimes we shudder at saying financial risk, so I'll just deconstruct that a little bit. We felt like there could be a more clear linkage between the payment methodology and some of those patient-specific or panel-specific outcomes of interest, and that's where we felt like the payment methodology was ultimately a little weaker. And currently, the other, just as a note, we spent a lot of time between the Office of the Actuary, CMMI, and some other experts to understand kind of how, what would this look like if you had multiple institutions with different financial arrangements, again, bringing up a kind of a feasibility or generalizability issue. So we did not feel with the information we were given that we would have a confident way of describing the kind of reproducibility or generalizability of both reductions of spending as well as the alignment with the suggested payment methodology. And then I'll go through the other criterion. We had another set of pretty robust discussions. You'll see that we did not reach unanimity on the value over volume, but we did feel overall like it did meet the criterion. And I think this is a hearkening to the premise of this model, which is really to offer comprehensive continuity for a group of high-risk patients. And we felt ultimately that if that clinical model can be better aligned with a payment model, that does offer significant value. And just to note in that slide, we did talk about that one of the comments in the HICI evaluation was that the empanelment or enrollment process proceeded a little slower than anticipated. We wanted to acknowledge that might be different depending on your institution, both either higher or lower, and that could pose additional barriers or obstacles, which could actually make the value proposition even greater. So we just wanted to point out that much of our data comes from kind of an institutional experience, which might not also be generalizable. The fifth criterion, flexibility. For all the reasons we said, various physicians can participate in this. You can be community-based, you can be hospital-based, you can be a cardiologist, you can be an internist, you can be a pediatrician. There is so much flexibility here, so we unanimously thought that met the criterion. On the ability to be evaluated, we also felt that if anything, we felt like this RCT design offered what we felt like was almost a gold standard for how do you think about evaluability, and much of that credit goes to the submitters in being pretty thoughtful and rigorous about that element of design. Now, we will say that having said that, the RCT trial is so compelling that we did have a little bit of opacity in understanding the difference between the HICIA evaluation results, which I've highlighted to death, and also what we know is in the submitter's proposal, and there have been some unpublished results to date. As of this day, it may have changed, but when the PRT met and deliberated over several weeks, we did not have any of those results that were a little different than the HICIA evaluation and are in the submitter's proposal. So I'll just highlight that as something that the PRT would like to have better insight on. Integration and care coordination. This was, anytime you see a majority and lack of unanimity, you can tell that there's evidence that there's a robust deliberation that went on. And I think that if I had to summarize where we had just some back and forth, it was understanding the roles and interactions, or more clearly defining how that leadership role for the CCP physician, that comprehensive care physician, would actually be executed with all the different touch points that any high-risk patient would inevitably have. So how do we make sure that, even though we know that in a kind of an ideal world that CCP physician is kind of handling and maintaining, even physically doing home visits or seeing patients in the clinic while also being in the hospital-based setting, we did not have the specific kind of process measures or some of the explicit expectations for those physicians, other than those thresholds and the penalty criteria that we described in the earlier slides. So we did want to flag that as a potential problem for care coordination, but I think the reason we did not have unanimity around this is because it's so clearly important to have this continuity of care, especially around a hospitalization period, that we were trying to understand how could there be more certainty that that continuity would be achieved. Next criterion, patient choice. We had a majority opinion, did not achieve unanimity, but we did think it met this criterion. We did want to make sure, I had mentioned that there was a potential risk for adverse risk selection, and so we wanted to also, it would have made us feel more comfortable if there were additional mechanisms to avoid, and I hate to say this has come up in many of our PTAC discussions, but we would love to acknowledge that everybody's trying to do their best, but we would have loved to also have seen, and we felt like the proposal could be improved with some acknowledgement of how to avoid adverse gaming, or doing something where you unintentionally disenroll a patient, wait for them to be hospitalized, and then re-enroll a patient. And you could imagine very perverse scenarios which we would like to have had more explicitly acknowledged, and that was part of the kind of robust discussion. But we did think that ultimately this is a really patient-centric model. Patient safety, we felt like that unanimously met that criterion. And it's in this case, we had a conversation about those very same unintended consequences, but we were trying to really acknowledge that if you have continuity of care, and the literature in transitions of care have long offered that adverse events are kind of the chief complication of a lack of kind of continuity and transitions. So we felt like this model head-on dealt with some of what I feel like has been decades-old health services research that showed that adverse events in a lack of transitions, and that's actually Eric Coleman's kind of body of work over his life, has illustrated how this could be a more patient-safe model. And then finally, my favorite criterion, health information technology, also felt like it unanimously met that criterion. There are issues of interoperability, et cetera. However, in their HICIA evaluation and award, they've been trying to deal with some of those technology barriers, and we felt like this model offered a novel way to approach some of that. So let me stop and ask if Paul or Tim have any additional comments.
That was a very comprehensive overview, Kavita. I think you've captured really our discussions well. I just highlight just this two. One is at least the concerns we discussed around applicability broadly, and that certainly in more integrated health systems, this might be easier to implement, still having concerns around in some more community-based, whether this is really feasible. And the second was around our discussion around integration and care coordination. And we even mentioned yesterday, we never passed this one on anything. And on the surface, you'd say, well, how could you not? Because you're actually addressing this care coordination by having the same clinician seeing the patient inpatient, outpatient. I mean, how more coordinated can you get? But I think our concerns were, as you reflected, were really beyond that, in terms of assuring that integration coordination beyond that peri-hospitalization period, and how would we do that. So I'll just highlight those two. Thank you.
Great. Thanks, Kavita. That was a terrific review. So I wanted to just reflect on a couple of things to highlight and emphasize things that you said, Kavita. It seems increasingly that we, as a group, are discussing the care model and the financial model, and looking at a care model that's been developed. Yes, Grace, you're the one that first pointed that out. And here, what we have is a care model that I'll read what I said here. More frail Americans with complex illness should have access to this clinical model. No question. It's fantastic. The question is, does the financial model that's proposed here necessarily result in the care model that's been created by by the applicants. And I wonder, you could also turn that question around and say, is it possible to create that care model using other financial models? And I would say, in answer to both of those questions, I have significant concerns, questions about asking that question both ways. And part of this has to do with personal experience, because in my institution at Mass General, we noticed about 5 years ago, maybe a little more, that there was a subset of patients who really needed high levels of continuity between inpatient and outpatient. And we have a group of, interestingly, primary care doctors who never stopped rounding on their inpatients and are not participating in the hospitalist service, which vast majority of primary care doctors do now use the hospitalist service. But there was this core group, and we started assigning our most complex, frail patients to that group. They get paid as primary care doctors and for their inpatient rounding under the current payment system. And I can't say precisely that they have all the bells and whistles that are here, but they do provide, in terms of continuity, we think of continuity in 3 domains, thanks to Barbara Starfield's work. We think of it as information. You want information continuity, you want management continuity, and you want relationship continuity. So there are multiple ways of providing continuity of those 3 things. But certainly the model that we have, without claiming anything like as good as what Chicago has, seems to be working on checking the boxes on those 3 elements of continuity. They're so critical for complex, frail elders. Now, you think about it, so primary care in my organization is heavily subsidized by the organization. So it is not actually standing on its own, it's subsidized. And so to generalize outside of our organization would be highly problematic. But the importance of what I'm trying to say here is one could imagine alternative financial models supporting this, and one could also imagine, I would say, this financial model not resulting in the care model that's been, at least with the controls that are proposed in this application. So sorry for that long, you said all that, Kavita, I just emphasizing that, so thanks.
Harold?
Thank you. A great report, Kavita. I have several questions for the applicant, but I wanted to ask one to you guys since you dug into this in detail. I was a little perplexed by this payment model where there's a threshold where you have to meet, and then there's a lower threshold where there's a penalty. And I wasn't quite clear on what exactly happens in the middle. So you have to be 50 and 67% to get the payment. You get a penalty if you're below 25 and 33 or whatever it is. In the middle, do you get nothing? And then you literally, so you get something, you get nothing, and then you get nothing and you pay a penalty? Is that what your understanding was?
Yes, that's our understanding.
And then the other question was, it sounded like the calculation was going to be made at the whole panel level, which I thought was sort of interesting given that this was all about continuity at the individual patient level. And you could argue that you could measure this at the individual patient level. You could say, did each patient get the full continuity of care? And you could potentially penalize you for not doing it on an individual patient basis and then add it up. And I wondered if you thought about that, because if you just do it at the panel level, then you have the potential for some patients are getting left behind, but as long as enough patients are getting completely continuous care, it ends up being 50 or 67%, even though some patients are really falling away, as opposed to saying a true outcome-based payment that would say, we will pay you if, for you, the individual patient, you got this. And did you talk about that issue at all?
We did. We touched on it, and I think certainly we should hear from the submitter about their thoughts further. I would just say that if anything, I think the reason you see this panel design and inherently these thresholds is really to offer almost a antithesis to like the current kind of, having to measure every little thing for every little patient, and this feeling like I'm just not able to deliver the care that I want to deliver. So if anything, you're correct. We thought that some of those, whether they're individual or at least more specific metrics, might be more useful. But we also really respected or tried to understand that there was a desire to simply make this a lot more flexible to be part of either another payment model. So you could imagine that if this were, there's a scenario in their appendix where they actually walk through the finances of what this would look like inside an ACO. That's inherently assuming that ACO, Tim's ACO, my ACO, Paul's ACO, we're doing all those ACO measures. So I think that the answer would be, not that they're all going to be inside of an ACO, but these tend to be organizations that are doing other things. Those other things are still not tackling this clinical problem. It keeps coming back to the fact that there's this unmet need identified clinically for high-risk patients. And that's why you see some of the kind of the lack of those specific measures.
Just to be clear, I was not asking about other kinds of measures. I was merely asking specifically about this thing because it seemed to me it gets at the issue you were raising about sort of the gaming and the whatever, is that if you have the calculation is made at the individual patient level, then I'm getting the $40 because I gave that patient continuous care, not because I somehow on average gave a group of patients something better than
You're correct. That's correct.
Greece.
As I'm listening to you, I have a couple of things I wanted to sort of flush out with you all before we get the speakers to probably reflect on it too, so that it may come about in their comments. First of it was the comments that you've made about the potential applicability across a broad a different setting than what the particular setting was that the University of Chicago's medical system was involved with. So did you all, in the research that was done, look at other places where there's been what we called extensivist models that were very, very different? So where there have been various issues. So I'm thinking of the CareMore, which in a Medicare Advantage was essentially a model where they were seeing inpatients and doing those. The work we did at Cornerstone Healthcare in the past was a somewhat different model. And then the third one I'm thinking about is at the Holston Medical Group in Eastern Tennessee, which was an independent group and an ACO. They had what they called their extensivist model, which was a hospitalist with a continuity clinic. So all of those were in different financial models, okay, but a very similar, potentially similar sort of comprehensive around the time of care. And there's been a fair amount published on all of that. So did that inform your opinions that you all concluded that this is, might not be applicable in other settings or not?
I think it actually supported kind of what Tim identified, that you can find other financial models potentially which could help you get to this same, tackle the same care issue. So yes, you were correct. It did not those specific CareMore, yes, but not some of the exact specifics. But that extensivist literature was something we were familiar with.
So that leads me to my second point, because that's where I thought you all were. And when you made the point, there's other ways of paying for it, but by the way, we supplement our primary care. I disagree with your conclusions, I think, based on my experience. So payments under the model are intended to be supplementary to other APMs, but it seems providers participate in other APMs could implement aspects of the CCP independently without additional payments. So you all put that in there as being a something that you were concerned about this particular payment model. So I'm not talking about whether I agree with the intricacies of this payment model, but you said it could be done elsewhere. So I'm going to talk a little bit about my experience and what I know about that. Within the context of experience that I've had in Medicare shared savings as well as NextGen. When you get the large health system CFOs looking at this, they see this as a loss, just like they do primary care. And you can make, as have many of these extensivist care model studies, show evidence that there is a clear savings at the total cost of care level, which is what you're wanting to see, you know, at the ACO level. But there is still a mentality that each individual unit within a total cost of care risk organization still has to sort of make it on its own, if you will. And so a lot of what I think the work that we've been doing at the PTAC level is trying to figure that piece out for various specialists trying to move the value, because the current healthcare you know, ecosystem doesn't buy that. They won't unless they're CareMore. Okay, so CareMore basically said, we're going to pay these doctors for giving really good care because we know it's going to save money and we're going to have some margin on that. Okay, we did some of that work at Cornerstone, but when we became part of a larger system, the consultants who came in, Marshall and Alvarez, basically said no. Okay, what's going to happen is every single thing has to make its own profit, or we're going to cut it and hack it because we don't believe in the total cost of care as part of an accounting system. My point in all this is how we actually think about making something look like it breaks even within the individual unit is what I think is a lot of what we're doing right now at PTAC, because it's, this is sort of, in many ways, Harold's approach to things where each thing that's important to do has to kind of actually be paid for the value that it does to the point that it can stay in business, right? So anyway, I want to sort of see if you all could comment a little bit about the statement you all made with respect to it could be done in other ways, because I think this is a crucial issue that we've got to understand, not only for this particular proposal, but for everything we see.
So I'll start, and I'm confident Paul and Tim will weigh in. I'll say that you're correct, as usual. I mean, your knowledge of what not just happened at Cornerstone happens in happens in all of our institutions, which is why I always shows primary care is in red on our CFO's, you know, tablet sheet. So it's constantly so, which is so. I think my answer to you, and we did not have that level of a discussion in any of our PRT discussions to that extent. However, we did talk about the reason we put that in black and white is not only did we kind of talk through extensivist model, what Tim is doing in the current fee schedule, I kind of offered from a community-based primary care side how aggressively, may not be the right thing to do, we're trying to aggressively increase our utilization of TCM and CCM codes to accomplish our continuity. So that's how we've answered that issue. And so in your Cornerstone example, where my unit would need to find a way to get into the black, that's actually how we're doing it. And I'm not so sure that this would offer, first of all, if I actually tried to do this, our hospitalists who are not integrated with us would completely mutiny and wouldn't allow for me to do this and would actually make things more difficult. And then I think Tim and Paul have kind of the other experience of running hospital-based or hospital-led payment models that have a component of what you're describing as well.
So to be clear, we couldn't get our hospitalists to do it either. We created a new specialty called extensivist and ended up having a relationship where some of them were hospital-based and some of them were clinic-based, and they worked together. Holston Medical Group did what I think these guys are doing, which is they basically took hospitalists and expanded them. And that's actually what Wake is trying to do now, you know, with our old model for that very reason.
I agree, as usual, Grace. It was a very insightful observation. I would interpret what we wrote there as, for example, and this came up yesterday, if I agree that the payment system should better line up costs with payment. Yeah. And we have lots and lots of examples in the healthcare system where costs and payment are not lined up. But specifically, there are a number of codes, TCM and CCM, we're doing the exact same thing So right now, billing for the various services, if you add them up, don't quite cover the costs of doing this, but that's not a payment policy design issue. That's a allocation of resources to the proper codes issue. Where one of the other things we get to think about in this setting is this issue of simplicity versus complexity. And if codes exist that are actually specifically designed to provide the resources to get this work done, why aren't people using them? Well, there's administrative reasons because they're so difficult to comply with. And that's actually improved lately. And they're maybe not valued correctly. That doesn't necessarily mean we need a new payment model. And so, do you see what we're?
Okay.
We actually talked about the recently implemented complex CCM code as an example of that. Like there was this perception, right, potentially that CCM itself was not valued for that subset of complex patients, and now there's additional dollars for a complex CCM. So that was part of our response.
So the way I was inferring, and I'm hoping that you'll comment on this later, is that the reason they're talking about this percent and that percent, inpatient, outpatient, is they're not thinking of a general internist like I used to be, who is doing an occasional inpatient case, but still has this vast primary care practice,
right, that's right.
and then sees them within the the month, the 30 days or whatever. They're thinking about a new specialty that has evolved from the hospitalist that's called a comprehensivist, that's basically taking a patient during a really crucial time and figuring out how to define that group and how it might work best for them. And so I guess the real question, and this is why I want you all to hear this now so I could understand where they're thinking and then go with where you might be, is just a transition of care code, okay, with the usual inpatient fee-for-service and the usual outpatient fee-for-service on top of that, adequate to support that care model and what I would call is a new evolving, developing specialty.
Grace, let me answer that first. What you described is, in theory, what this is. I would say that that's absolutely the intentionality of it. However, it gets back to what I think all three of us have said now. I don't see evidence to reflect that if you simply reproduce this payment model, that you would achieve that.
But that's your beef, though,
let me
right?
tell
Because
you
that's
that
what
that's
I-
probably
that's
the
what I
crux
think,
of our
yeah.
issue.
Okay.
Those of us that have any clinical care experience know that that's what we want to get to.
Okay.
It's not clear that this is the
That this doesn't,
mechanism
okay.
to do
All
it.
right, so
Does that
so
help?
that's what I thought this was, which is they have defined a new way of thinking about a payment for a new way of providing care for what's an evolving new specialty. And your argument in here is there may be other ways of getting there that are already out there that could be tweaked. And their argument is, this is the way we think it could be done. That's your understanding of
Right.
it. But we disagree.
And for example, in that comprehensivist model, there could be a comprehensivist of the day, and it could be Tim Ferriss on a Monday, Kavita Patel on a Tuesday, Paul Casal on a Wednesday, and we're kind of the comprehensive.
Yeah, that's called a
system.
hospitalist service. But
Right. So I'm just offering to you a little bit of where I see some loopholes in this current design.
I also want to respond, and sorry, I can tell Jeff is wants us to get on to the show here, to the real. But I do want to, one thing you said, just clarify. So one of the issues that we discussed was the creation of this model seems to add an additional level of complexity to the number of transitions that occur, because you described it as a hospitalist that becomes an extensivist. Actually, actually, the model that we have is, and it's not of limited duration, and then you pass it on. We have primary care doctors who have smaller panels, who round, and they round on their patients. So it is not sort of a rotating basis. They actually specifically those frail, complex patients don't get admitted to the hospital as service when they get admitted. They get admitted to that person, you know, unless they're away on vacation. And so you really are creating, and there is no transition on the other end, you know, after a year or 6 months or whatever it is. They are their primary care doctor, and they are their hospital doctor.
That's why I wanted this conversation to happen now.
Yeah.
That's why I wanted this conversation to happen now, is so we could understand what you guys were thinking this was, because I want to hear if they think it's the same thing or not, so that we can flush it out one way or the other. So.
All right, thank you. Len, please.
So, having now heard 4 doctors talk for an hour,
We're used to economists.
I'm ready to point out that this PRT had 3 docs. I know there's a rule against having 3 non-docs. You might want to just think about that. But so here's why I'm confused, among other things. Every single one of you on the PRT, first thing out of your mouth was, more people need this. And then you imagine 87,000 things that might go wrong because it's not documented in the quality measures they put forward because they're trying to do it simple. So here's what's going on from an economist's point of view. These guys are trying to incentivize a style of care. And the style of care has to do with this mix of in, out, all that. Call it whatever incivist you want. It's about a style of care that doesn't exist now very many places. Apparently there's 12 people in your world who voluntarily, because God knows y'all wouldn't make them, they're voluntarily doing this, right? And I would submit this subsidy that's going on is actually, CFO knows damn well they're getting total cost of care down because of it. So it's not a subsidy, it's just, okay. But here's the question. It seems like the assertion of the applicants is this style of care will generate all the good stuff and savings. And it seems to come down to a factual dispute about whether the HHS evaluation that I guess after somebody did, whether those results are, if you will, dispositive, or whether the recent results are dispositive. So I think that's the thing we want to understand. Okay, that's sort of the way I see it. And to me, it's quite analogous to what Chris Kohler was trying to do when he was insurance commissioner of Rhode Island. Let's just make them spend 10% on primary care and see what happens. And turns out there's recent results you may know about that Bruce Landon and his team did that would suggest these styles of care actually can have impact. You know, everybody's talking about anecdotes. It reminds me of a doc I once knew who ran one of these early on Medicare Advantage products, and he required, he had a practice that was treating non-Medicare patients and Medicare patients. He built a new building for the Medicare patient world, and he made his doctors spend 30 minutes with them. And the first 6 months, the doctors went crazy. What am I going to do with 30 minutes? I usually spend 11. I'm going to talk about their grandchildren. He said, that's the friggin' point. You learn everything about them. Utilization went down by 20%. So fundamentally, it's about a style of care, right? And the question is, does the style produce it if indeed it's being done by the right kind of people? Yes, it doesn't exist very many places. Yes, there's serious question about if you set this up, how many people would join it. But it seems to me the question is, have there been results that go with this style of care enough to justify beta testing? Am I wrong? You're nodding yes. Am I wrong?
So I think he's on to us.
Okay, Rhonda, go ahead. That's
good. Bob?
Well, now that we've heard from the economist, let's get another clinician in this. First, I want to say that Tim's comments, I'm shocked to hear there's misvaluation in the physician fee schedule.
Never been said.
But we'll leave that aside. We have nothing to say about the fee schedule here. I followed this conversation, and I have a concern about the fact that lots of organizations have figured out how to do this sort of naturally. And would we be, by deciding that we would support this model, somehow be then adding lots of money to the pot for everybody else who's doing it? A lot of groups, as Tim has emphasized, is just have a normal triage function where some of the docs are the hospital docs, and they follow the patients for the practice who are maybe the first time, and then the patient moves their care from Dr. A to Dr. B, who is taking care of, who's expert at COPD or some, serious illness. So my question is really to try to estimate the magnitude of what we might be talking about. We've gone in 20 years from having physicians, when I was practicing, following our own patients in the hospital, to an assumption that nobody follows their own patients in the hospital, and I don't think that's right. So the question is there any data, I could imagine looking at TINs and place of service or whatever that would, so that we actually know how many patients are followed by an office-based doctor, I guess is what I'm saying, who are in the hospital. How big is the potential universe? Did you guys look for that at all? Is this a rare event that doctors follow patients in the hospital from their practice, or as I suspect, it's happening a lot more than sort of than the assumption that hospitalists have just taken over all hospital care. Do we know anything about that?
We didn't, as you know, we could run kind of secondary data, but we did not do that specific level. We did not do those data analyses, no. And we know, we also looked at the literature, and then I think aside from what's in the packet, the three of us have tried to look for some sort of quantitative evidence of that and did not I did not find that, no.
Okay.
But we would concur with your impression, with no data to support it, that there is probably trends, and they're largely probably geographical and correlated with institutional type potentially, that would predict some of that, rural, urban, et cetera. So we would support your hypothesis.
Yeah,
but didn't do anything to explore
I'm
it.
guessing that rural docs are largely following their own patients.
And we feel like yesterday we had a PTAC submitter that probably echoes some of that.
And that was going to be my final comment, is this is just a different version of what yesterday's proposal was about, is that people get lost in the emergency department, in the hospital, without any natural follow-up. And so to emphasize, this is a real important issue, and there may need to be a few different approaches to trying to deal with it, but I think it raises the issue of taking proposals one by one rather than taking a topic and then trying to figure out what are the various ways of attacking, for future work for PTAC. It might be something to think about, is to offer proposals on particular topics that we find compelling. Whether CMMI would find that compelling is a whole different story, but I just find this is a recurring important topic, is the patient lost between the hospital and the home.
So, as another clinician, I feel compelled to pile on. And this is in part, I'd like to hear from the applicants, but also we're talking about applicability, and I'm not an internist, but a surgeon, but I did lead a large physician group in an integrated delivery system. And my experience were people wanting to really focus on being hospital intensive. So there were laborists, surgicalists, extensivists, hospitalists, recruited a lot of primary care physicians every year. And there were primary care physician candidates that wouldn't even entertain our organization. And we had hospitals that were as small as 30 bed in a 10,000 population communities. They wouldn't even entertain and looking at us unless we had a robust hospitalist program. So we talked about application, and it's, you know, any great model, if you can't get people to engage, and I think that's the question that really Bob was trying to get, is what's the universe of potentiality look like? And I understand what's experienced in Tim's organization, and that kind of thing is happening both in these large integrated multi-specialty medical groups, also in rural communities where they don't have any options. They just don't have that ability to recruit a robust hospitalist team because they don't have the inpatient volume. So that's a question I'd like to understand, and I think, Kavita, it sounds like your committee discussed that. The other point is, in your proposal, you commented on the fact that you needed enough complex patients in a panel to make it worthwhile for the hospital, this individual, to be in the hospital. But at the same time, they also have to be in the clinic. So it's kind of like back to the future. I think that my question is that creating the same kinds of challenges that drove us to become a hospitalist kind of delivery system now, because things don't happen just in the morning and they don't happen just at night. And so if the individual is in the hospital and one of these sicker patients shows up in the clinic and they have an acute problem that could be addressed in an ambulatory environment, but they're in the hospital, and now, you know, you understand where I'm going, and that's my concern. Is this is a very I'm not talking about the payment side of the business. I'm now talking about the actual clinical applicability of doing this. And then if you strip these patients out of the hospitalist community, then you're turning that dynamic on, because the hospitalist is staffed with a typical number of hospitalists to support a population of patients, which now this particular model is impugning. So those are my thoughts, and I'm hopeful that you'll be able to share those. But I'm also, for you guys, Paul and Tim.
So you sounded a little apologetic that you're a surgeon. I don't know.
Did I? Well, because I know if I didn't, you guys would make me would remind me of that. Okay.
But I think just to emphasize that was certainly, we had a lot of robust discussion around those particular points, and we look forward to hearing some more from the submitter around that. But
we did talk with a clinical expert, a hospitalist based in a large integrated setting. The transcript's here, and he very bluntly, we wanted to do a little gut check and make sure we weren't just in group speak. And he said, you know, it would be potentially hard for me to even recruit from my own hospitalist group people who would want to do this, because a lot of the people who came into hospitalist medicine just wanted to do dedicated, discrete, you know, shifts, hours, et cetera.
Right. And my last comment is there were a number of candidates who said, I don't feel comfortable. I've been out of inpatient medicine. I don't feel comfortable now working in an inpatient environment. And I know you guys, I think, were supportive of the patient safety issue, but that's another question that I'd like the proposer to comment on. Thank you. Bruce.
Since all the docs have been piling on each other, I feel the need to pile on with Len a little bit. So, oh, okay, all right. So I thought it was kind of ironic in the PRT report. I mean, you know, clearly there's lots of evidence that handoffs are often a problem, right? Bad things happen when handoffs aren't handled appropriately. And their proposal proposes to deal with an important handoff situation when the patient is hospitalized and then what happens next. The irony is that the PRT was concerned about, well, what happens 30 days later whenever there has to be a handoff back to the delivery system that the patient was a part of. And I guess my response to that would be, well, okay, I mean, that's obviously a situation that needs to be dealt with, but if the more important handoff from both the clinical and economic perspective occurs at the point that's been highlighted in this proposal, then maybe the fact that there's another handoff situation that has to be dealt with is sort of a secondary concern if the more important, both clinically and economically, handoff is the one that they're focusing on. in the, what you call the peri-hospital situation.
Yes, we would need some data to support that delay in handoff doesn't create, obviously the peri-hospital time has been what's studied because that's been the area with the most numbers of handoffs. Our point was simply that you could potentially be creating additional adverse effects by delaying those handoffs for this population of patients. It's not to say that that delay is in and of itself, you know, a disaster. It's just that we don't have data to support what that would look like. But a handoff would need to occur.
Happy to provide it for you.
You can feel free to submit to PTAC at HHS.gov during your spare time.
Public comment period.
Exactly. No. But that's just the point to bring up, that we just, that was a largely hypothetical, but something we didn't know.
All right. Thank you. Great discussion. I'd like to now have our applicants please come to the table. I believe you have prepared remarks. We'd like to keep those to 10 minutes if possible, and then clearly you've heard the dialogue, so addressing questions, and then I'm sure there'll be more.
Okay.
Thank you very much.
Great. First of all, thank you so much for having us here. We are incredibly excited to talk to you about this work, and we're grateful for the attention you've all given to it and how hard you've worked. We saw it yesterday. So we know what tough work this is. I come to you as a general internist by training, but also an economist. And also as the chief of hospital medicine, so I run our hospitalist group, but also a practicing primary care physician. I have had my own panel of patients for 20 years. The average age at this point is probably 85 plus. I have a deep understanding of what it means to know a patient and work with them over time, and that at the core is really what this proposal is about. With me, I have Andrew Schramm, who is a physician in our hospitalist group who's leading a new form of the CCP program that we may talk about at some point, and is also an MBA. And on my left, Emily Parrish, who's a graduate of our public policy school, and she directs innovation and sort of program development for the CCP program. She also has another very critical qualification I didn't know about until I'd worked with her for over a year, which is that her mom is a primary care physician at a local community hospital, one who still sees her own patients in clinic and the hospital. And I think not just because she's Emily's mom is actually helping us develop this same program in a community hospital. So we'll address that very directly. As I mentioned, the CCP model itself and the payment model at its core are fundamentally about promoting continuity in the doctor-patient relationship. This idea, which I think, and the value of the doctor-patient relationship is of incredible importance. I always go back to Francis Peabody's classic 1927 article on the care of the patient, which, by the way, was in his last year of life. He wrote very personally in that year. And he writes, "The secret in the care of the patient is in caring for the patient." That, that statement, which is so elegant, it's often been misattributed to William Osler, really states the value of truly knowing the patient. And there are similar things in Marcus Welby in popular culture. Today, we probably would call this patient-centered care, but it's an idea that goes way back. And I think this is an idea all of you believe in. If you've had personal experiences as patients or family members, or certainly as clinicians, you've seen the challenges of discontinuity. But just to solidify the role of John Wasson as the sort of hidden hero of this PTAC meeting, I want to remind you not just of his What Matters Index and What's Your Health work, but a paper that wasn't mentioned in your excellent review of the literature on continuity, which is a 1984 paper done in the VA, published in JAMA, where he randomized 800 complex patients in the VA, either to get primary care from the same doctor in every primary care visit or a completely different one, okay? This is an amazingly important study. The continuous care group had 49% lower emergent hospitalizations, 38% lower hospital days, 74% lower ICU days. RCT only changed continuity. Okay, So, nevertheless, since the 1980s, medical care has become increasingly more fragmented. And nowhere is that more true than in the division between hospital care and ambulatory care in general medicine. And it's particularly bad for the most frequently hospitalized patients who get a different doctor every time they come in the hospital. Okay? And this is not a small niche problem. This is a huge fraction of medical expenditures. Okay, so this is what led us to this idea of the comprehensive care program. I want to be very clear about it. This is not an extensivist model. We do not care for the patients just when they leave the hospital for that short period afterwards. We take over all their care on a continuing basis, both in the hospital. It's much more like the model Dr. Ferris described. Okay, so this is continuing care in the hospital and out of the hospital. So that's the key idea. Now, we're really grateful for the thoughtful review. We were pleased we met 6 of the 10 criteria. Unfortunately, 3 of the 4 that we failed were the high priority ones. So I really want to focus on those high priority criteria, and in general, the 4 that it was assessed we didn't meet. And if I fail to answer any questions that have been raised, I ask you all to remind me of them. First criterion, expanding the scope of the physician-focused payment model. I want to emphasize, first of all, this is a model that's open not just to PCPs in an ACO, but to PCPs who are not in an ACO. So that alone is an expansion beyond the existing models. So that is, I also want to emphasize that we are asking physicians to change their whole practice panel, to take on a different set of patients. This isn't something you do contracting with someone for a year. This is a lifestyle decision. And it's very durable. And with all the turnover in ACOs and contracting arrangements, the stability of this incentive we think is key. I also want to emphasize that there was this argument that, well, ACOs could do this anyway, and should we really be paying them more to do this? And I would argue that we should, and one of the reasons is we want to increase the incentive to do this. And I was trying to think how to describe this, and the best example I could come up with is to describe my 4-year-old. Okay, so I have a 4-year-old daughter. She's a pretty good eater, but sometimes she just doesn't want to eat her dinner. I, being a rational economist, tell her you should really eat. You need the nutrition. You're going to grow up and be big and strong, and you need to do that. My wife is a much more practical parent. Okay, she's like, if you eat dinner, you can have dessert. Okay, she should be doing it anyway. That's the daddy approach, but it's the mommy approach that gets her to eat. Okay, and I would point out that, Tim described an organization where a rational process was made to adopt a model like this. Most ACOs are not in the position to sort of think about things this easily. I would argue even if they are, this has a cost of about $300 per patient and a return of about $3,000 per patient per year. So it is worth spending a little more money to make sure this happens, particularly if you're doing it in the context of an evaluation where you can prove it happens and then produce that change on an ongoing basis. I also think that your endorsement of this would increase awareness of it. I think your control of this process and CMS's control of this process would increase the knowledge that is generated. We're proposing a beta test to generate knowledge with evaluation metrics, including things like improvements in care experience, improved health, improved cost, decreased hospitalizations. Those are not payment criteria, but they're evaluation criteria. I also think this is novel in creating a cross-cutting APM that overlays other APMs, so that extends the scope of physician-focused payment models. There's worry that patients wouldn't enroll in this. I can tell you we've enrolled 2,000 people, 4,000 people in a randomized, 2,000 people in a randomized trial at the University of Chicago over several years. We easily could have enrolled twice as many people if we didn't have to do it in a trial. We got great help from CMS and HCA and sort of learning how to enroll. We know how to do it. I will also point out if no one enrolls, this program costs CMS nothing because the payment is per patient. Okay. There's worries places won't adopt it. As I said, we've done it at the University of Chicago. We're learning how to do it at Ingalls Hospital, this community hospital. We're finding other local hospitals in the Chicago area that are interested in doing it. Vanderbilt has adopted a model like this. Kaiser is doing it. We've gotten interest from Blue Cross Blue Shield Association. I'm going to be presenting at their medical directors meeting next month. I think Brian Grayson was very clear that he was interested in this model and wondered if Penn could do it. We've had interest internationally. We really think people will adopt this. I also want to point out that in terms of recruiting physicians to do this, we have found residents who are interested in coming into this. We found mature doctors who are willing to do it. It does not need to be for everyone. My guess is that if 5 or 10% of internists in the United States did this, you'd saturate the vast majority of needs. There are plenty of people to do it. Second criteria, does it improve cost or quality? I'll point out we have these strong results from an RCT with big improvements in patient satisfaction score, self-rated mental health status, and reductions in hospitalizations. I will point out those are all patient-reported measures. Okay? The claims data, which the HCIA evaluation looked at, has a series of limitations. First of all, it was only for a part of the period. More importantly, there was a fundamental bias that arose in it. And the bias arose because in Illinois during this period, there was a very strong push to push Medicaid patients into managed care. When they go into managed care, we lose their claims data from the claims data, and HCIA loses it. Who went into managed care? They were the lower utilizing people. The high utilizing people stayed in that program, in our program, because they wanted really good care. The data for this is in our August 27th memo to you. You can take a look at it. I will also tell you that the data we have from claims data and self-report for the period for which we have complete claims data, albeit incomplete, align very well. We are getting the claims data. It's just going to take a while. For those of you who know the ResDAC process, we are working through it. Quality. I want to point out that we have these structural and process measures. We think they are of value. We also want to point out that in terms of outcome measures, we require all the measures from the additional payment model. So if you're in an ACO, you have to still have all the quality measures that you would have in that ACO. They're all still measured. We didn't want to force additional measures on top because we know there's issues there. I know I just have a minute more. Can I run over a tiny bit on that? Okay, I'll take that as a yes. Okay. Yes. There's concerns about, and we're open to adding more measures. We worry about risk selection. We should add the more measures we choose. We try to take the sickest patients. Their measures look terrible. We don't want to be penalized for taking the sick people. We want to care for them. Empanelment, there's a concern about selection risk. With the way we've got it, I don't think that is a problem. I'll come back to that with more time. For the payment methodology, which is the third high priority criterion, we've already addressed the issue of whether an incentive really is needed. We think it is. We do think there is financial risk, not just the $24,000, but the fact that you have to block off your clinic every morning to be able to care for these patients in the hospital. That's a huge financial issue. There are cash flow issues about payment. We think those are easily addressable. There's one argument in ways ACOs are already incentivized to increase continuity. This just isn't happening in most places. In fact, the state of Illinois, our Republican governor signed just this past week, I believe, a bill requiring that patients be allowed to opt out of managed care organizations at any point in time if their PCP leaves, because continuity is such a terrible problem. Finally, integration and care coordination. We have developed a strategy in this so that people, the CCPs see their specialists and actually relationships deeper. We do think we sort of nail preventive care, although the prevention I would talk about is tertiary prevention, keeping people out of the hospital. That's what matters for this group. We've talked about quality measures already. I want to add one more that I think is critical for you to hear. The real incentive to provide good care for patients in this model is that they are your patient. If you screw up their outpatient care because you don't answer their call and they end up in the ER, you have to look them in the face the next day, explain why you didn't answer the phone, and explain to all your colleagues why that happened, okay? And that, I see that as the leader all the time, and I think that is just absolutely essential. One last thing. I think we've talked about sort of this issue of delaying inevitable handoffs as hospitalization risk falls. Again, we don't think these handoffs are inevitable. We've managed for 5 years to have people enrolled in this program. We have never taken anyone out of the program because they're not sick enough, okay? We just make them well and keep caring for them. So let me just conclude. I think these are important responses to the important criticisms that were raised. We heard additional criteria of the administration. yesterday around transparency, simplicity, accountability. I think this is very simple. We're going to pay someone to be your doctor and take care of you, and if you're not happy with that, you talk to them about it, and if you don't like it, you leave. We also heard about the 4 Ps, patients, physicians, payment for outcomes, and prevention. I think we nail all of those. I will also add that we've had additional funding recently from the Robert Wood Johnson Foundation to add another component to prevention, which is social prevention, which is addressing unmet social needs. Some of that involves additional resources, but what is the foundation of it is that relationship between the doctor and the patients. Our doctors know when their patients are having trouble applying for benefits. They know when their family is experiencing an issue, and they use that to make them better. So let me stop there.
Thank you. Harold and then Grace.
Thank you. Thank you for your passion for this. It's exactly the kind of thing that I think PTAC was created to try to help people who are doing things like this get a venue to be able to make them work. I guess I would preface this by saying that I absolutely support the idea that you're trying to get to, which is more continuity of care. Just as a very quick anecdote, I had an experience several years ago. I was working with a medium-sized multi-specialty group, mostly primary care, on a readmission reduction project, and they were just at that point decided to move to a hospitalist model, because the PCPs were basically saying we just can't afford to keep going to the hospital every day. And so they made this switch. 2 of the doctors who had been basically, you know, primary care physicians like every other primary care physician in the practice dedicated themselves to the hospital. And all the other PCPs then immediately started to complain about how those 2 guys never ever called them, were changing everything about the way their patients were being managed, et cetera, et cetera, et cetera. So it's clear that it's all of a sudden where you stand depends on where you sit. So I have a couple questions, if you'll bear with me, Jeff, because they're kind of interrelated. And the first one is, you've sort of characterized this payment model as an incentive, as a nudge. The first thing I want to understand better, though, is, that's why I told that story, is that people have moved to this model that exists today, this undesirable model, because they felt that the payment model did not support them being able to see patients in the community and see patients at the hospital. So my first interest in a payment model is, does it actually remove the barriers that exist in the payment model today, and does it create any undesirable incentives? So I guess the question is, and it's useful to talk to you because you've actually done work in terms of what's it cost and, you know, et cetera. I'm trying to understand, first of all, so if somebody sets up their practice the way you're suggesting, and forget the $40 for a second. Yeah. If they were, because if I understand this correctly, it's an add-on. So they're still billing for E&Ms outpatient. They're still billing for E&Ms in the hospital, et cetera. If they did that, would they be able to essentially do better, do worse, et cetera, revenue-wise than they would, you know, otherwise?
Yeah, can I answer that?
Yes, absolutely.
Perfect. Okay, so this is a great question. So with more time, I would have started at the very beginning of this story, which began with, why is it that hospitalists grew, okay? And one story was they're better, but, you know, probably not. The other story that we came to, and this again was with funding from the Robert Wood Johnson Foundation, is that hospitalists grew because primary care doctors could no longer do the job they used to do of seeing their own patients in the hospital in the morning. And the reason for that is not that the payment model changed, but that the epidemiology of illness changed. It used to be that people went to the doctor because they were sick. And if you saw a fair number of people in the day, a fair number of those people would be in the hospital the next morning. Okay? Over time, what happened is people started going to the doctor to stay well. So you could be busy all day long, you know, checking blood pressures and mammograms and pap smears and all that good stuff, okay, which should be done. But the consequence would be very few patients were in the hospital. So you couldn't block out your morning only to have 1 or 2 patients in the hospital. This is, in fact, exactly what Emily's mom is struggling with, and many primary care doctors along. So the fundamental change is a reorganization of the practice to focus on these patients at high risk of hospitalization. So once you get to that point, the RVU generation is not wildly different than someone who, you know, just does one or just does the other. It's really a sort of
Yeah,
hybrid.
so in other words, the answer to my question is, if you structured the practice the way you're suggesting and focused on the patients, you would basically be able to do the same revenue-wise. There is no gap that the $40 is trying to fill.
So what I would argue is, so I think that, I mean, it's a little bit of a hypothesis to see what we get to at the end. We're kind of maturing now, but it is not wildly different. However, there is a big transition that needs to take place during that period where you've got to block out your time in order to do this. You've got to build up the volume to make this work. So, you know, the way this model is set up, we sort of pay the $40, right, when people are sick, and at some point, you know, it drops down to the $10, and that's a much smaller number, obviously, over time. But we think that these payments are critical. If you asked me, you could do this, do it for a period of time, and then, you know, maybe
so
trans
you're
someone down to lower levels.
This is a bit like a new startup business, is that you go through sort of valley of death, and then you'll be back and you'll be okay. So in other words, there's a short-term thing, but in the long run, you should be able to do okay. Okay. So
can I say one other thing?
Yeah.
It's just a related. This is a more complicated idea, but I think it's worth describing, which is that, you know, when CMS makes payments, they make payments to a bunch of specialties, right? And they have, you know, it may be that this is an important payment, and maybe, you know, later on we don't have to raise pro fees quite as much to get people attracted into this specialty because this payment to doing this is already there. In that sense, the cost of this is zero. So I realize it's sort of theoretical.
So the part two of the question, so there's no sort of in the long run cost gap. There's a cost gap in the short run that you have to fill. And whether the $40 is enough to do that or not, we can discuss separately, but so short-term gap. So the second part of the question then about the payment model is, one of the interesting things about the current structure is that it's sort of neutral to whether the patient's in the hospital or not. Because if I see the patient in the outpatient clinic, I get an E&M. If I see them in the hospital, I get an E&M. Now, organizing your time is a different issue, but you basically get paid either place. You've introduced an interesting situation here where it seems as though you've actually created a penalty for somebody to keep them out of the hospital. Because if you, in fact, get the patient healthier, manage them better, and they stay out of the hospital, you lose your $40 because the patient's no longer being in the hospital anymore. And if I've structured my practice around being at the hospital every morning and I'm keeping my patients out of the hospital, then all of a sudden I'm losing all my hospital E&Ms because I'm not seeing the patient in the clinic. And it seems to me that it's sort of perverse in that sense. And I guess wonder what you think about that, but I'm wondering why you wouldn't just sort of pay what we're trying to do in a lot of other models, is pay a PMPM to the doctor, regardless of where the patient is, so that all of a sudden, because you've left the underlying fee-for-service structure in place, which now all of a sudden says if I keep you out of the hospital, you lose all the hospital E&Ms, and you're not potentially going to make them up in the clinic because you're not going to be in the clinic.
Yeah. So two things. First of all, I mean, I understand the theory behind what you're describing. In practice, we're not that good at keeping people out of the hospital. You know, we have like a 30% mortality rate or 20% mortality rate in 1 year, sort of more like 30 in 2 years. So we're constantly getting in new patients. So we've been doing this for 5 years, and the problem you've described, you know, it really hasn't gone away. Now, why didn't we just go to a pay, you know, per patient per month kind of capitation thing? And the reason gets back to risk adjustment and selection. Okay, we are trying to take care of the sickest people. We go down to the ER every day. We try to find the sickest people. Risk adjustment is not that good. If I told my dean I wanted to go off and find those people, I'm not sure I would be sitting here with the University of Chicago affiliation. I mean, we are trying to create a model that is not victim to the incentives to cherry pick. And it affects our quality measurement approach. It affects our payment model approach. I mean, you know, I'm an economist, I get it, capitation, all that stuff, but I'm also a realist. And we have serious problems in risk adjustment, and this is the sweet spot of the ultimate failure of risk adjustment.
But if I understand it correctly, you're then relying on the fee-for-service structure to risk adjust for you by paying more if a patient needs to be seen more, but it seems to me that you've created a perverse incentive in the other direction, which is that success. So let me just, because I'm interested in time, let me just go on. So the third related question to this is, I'm trying to understand better sort of who these patients are. Because when I first started reading the proposal, my immediate reaction was it's sort of our standard chronic disease population that we basically end up, they go to the hospital periodically for exacerbations, and we want to make sure that they're not getting sort of screwed up by somebody else when they're in the hospital, and if you keep them out, all is a wonderful thing. And as I read more and understood the model, and I saw Tim's compliment about the New York Times story, I hadn't seen the New York Times story, so I read the New York Times story, which then gave me a better sense. And I suddenly realized that these were very different patients than that. But it seemed to me that they could potentially fall into multiple categories. I mean, you had everything from what you might call end-of-life patients to patients with extraordinarily severe diseases that might need periodic planned hospitalizations for treatment, et cetera. And you don't seem to have made any distinction like that in the model, and I was surprised that it was triggered by one hospitalization. Because when I was reading the story, I was reading about patients who don't just, their characteristic is not that they just happen to be hospitalized once, but that they really have kind of, a disease complex that is causing them to be at high risk of constant hospitalization, but you didn't define the criteria that way. So I'm wondering if there really is a segmentation, whether you group them all together because you need to get enough volume to be able to make it work or what?
You just hit it. So a couple of answers. Great question. So first of all, yes, some of these people are at end of life. Some of them have COPD. Some of them have diabetes. Some of them have end-stage renal disease. Many of them have most of these things. Mm-hmm. So chronic interlocking illness is key. I'd also add sort of social determinants of health there. So those are big reasons that we don't go sort of disease by disease. But the other issue that you raised is really critical, which is one of volume. We wanted to have enough patients in this program to make it feasible so that we would be able to have enough volume in the hospital, enough we had to do an RCT, we needed to power for it. I mean, these were very practical concerns, and it makes it more scalable. And getting back to your earlier question about kind of what's the long run cost, if someone ends up a low volume kind of person in this model, the costs become very minimal of having them in it. And again, the returns, particularly for an ACO, are biggest the sicker. And what we find is, even though this threshold is one hospitalization, the vast majority of people who enroll have many more than that, because people don't want to change their doctor for nothing. They change it when they see a compelling reason. And that's also how we talk to them about it. So that's a minimum criteria, but the average is substantially more, as you would expect.
And final question is, it's, I guess, the notion of the model of care is certainly desirable, but you've created a model which essentially mandates a process. You've mandated a particular structure, and a randomized control trial might say, yes, it's better on average than something else, but you've essentially taken away the flexibility for physicians or practices to figure out how to do it differently by saying they have to be at 67% and 50%, et cetera. And I'm wondering why not just hold people accountable for the outcome. If you think that there is an outcome that they can achieve, if they think that they can reduce hospitalizations, then say, hey, we'll pay you whatever the different payment is, whether it's $40 or whether it's a PMPM or whatever it is that needs to fill the gap to be able to get through the valley of death, whatever, to be able to get to this, to say, we'll pay you that, but the outcome, which is essentially what we need to be able to do to show Medicare and MACRA that their savings, is that you actually have reduced something. And then, if this works, if people sign up for it, they would say, well, the best way to do that is obviously to have continuity of care and to schedule myself around this, et cetera, but I wouldn't be all of a sudden worrying that, in certain cases when I went on vacation, I was going to fall short of the 67% threshold.
Yeah. So we tried to build in as much flexibility as we could to make the model broadly applicable. So that's why we didn't get even more specific in that area. Why didn't we condition this on outcomes? It's because we believe that it's too tempting to want to avoid caring for taking on the hardest patients on these. 1 or 2 patients like that kind of destroys your statistics, and those are the people we think we help most. We don't want to be penalized for taking the sickest people. That's who we want. And I'll point out that to the extent the organization has already taken on the responsibility for those people at an ACO, that incentive is already there, okay? So we didn't want to add on top of it. We didn't object to its existence, but we didn't want to saddle this model with that obligation because we think that it is risk adjustment just doesn't support the discrimination needed to avoid having you be penalized for taking on these, very, very complex patients.
Grace?
So I'm going to ask my questions to give you some context. As I mentioned, I'm a general internist, and when I started practice in 1993 in what was at the time pre-electronic medical record, pre-hospitalist practice, I would be on call for 8 physicians, see patients in the hospital, had a nursing home practice as well as an outpatient practice, and loved to take care of sick people. And I was the last one in town who actually gave up my hospital practice. So to my mind, my ideal practice would be exactly what you're doing and achieving. It's exactly what I like to do when I'm seeing patients. But it got too darn hard. So you've spoken of other incentives that are out there. It became the first people to go to a hospitalist program were the family physicians who discovered that if they focused on all the things you mentioned, prevention, lots of quick E&M visits in an outpatient setting, they could make $30,000, $40,000, $50,000 more a year and not have to be all the concerns about being on call at night and not have to worry about the sickest of the sick patients. Then in our community, you started seeing the internists dropping out of call because of the motivation on the part of the hospital to go to a hospitalist system, because then they could pay RVUs and do a lot of DRGs and churn inpatient volume. And so there's, I think, a larger reason that that we got to where we want. It was in the hospital's interest to have efficiency at the level of hospital care. And it was and then you ended up with a bifurcated system where for many clinicians, they had a better lifestyle, and I'm talking a much better lifestyle. So what you're trying to solve for is what was created as a result of how hard it was to do what you and I both know is just a much better way of practice. Yeah. So a lot of what we've been doing since then is trying to sort of fix what we broke, right? So I want some very specific questions so I can understand what it takes to fix that, at least as you understand it. Number one is, if we use the term panel size, okay, how many patients does it take for a clinician practicing like this to have in his or her panel to make a living and not have such a horrible lifestyle that they leave this program? Yep. Okay. So and then the other two, and the other one related to that is there a call group size that has to be done? So these are very practical things. I got them. What's the answer to those two things? And I'll go to the other things right quick.
Good. Thanks for not straining my cognitive ability to answer 3 questions. So first of all, there's some underlying theory behind this. There's this idea called an adaptive organization perspective to sort of design. Clay Christensen has written about this idea of sort of solution shops. And what fundamentally makes this manageable, and what's the difference from probably the job that you had, is you're only focused on this group of high-risk patients. So you don't have this overwhelmingly large clinic that is impossible to manage. So that is the fundamental theoretical insight that makes this doable. We have done that with a pure CCP model at a panel size of about 200 patients.
That's what I thought. Perfect.
We go to a little above it. Sometimes the longer they're in the program, kind of they get more stable, and the doctors get better and know them better, so they can get a little bigger. I don't think you have to have a panel size of 200 to make it work. One of the reasons why a smaller one might work is if you have other ways to backfill inpatient volume. One way to do that is by being what we're starting to call a rounder model, which actually was something when I was in Boston, we saw at the time at the Harvard Community Health Plan, where basically you round on your colleagues' patients. So that's a way to do it. Andrew's working on developing that model at the U of C right now. We think that could work in community and rural settings where volumes were lower. So that answers one of the generalizability questions. Call group size, we do it with 5 docs.
Okay.
And the way it works is everyone sees their own patients in the hospital every morning, Monday through Friday. They have multidisciplinary rounds in the late morning. One of them stays through the afternoon and is sort of the hospitalist for that group that day, seeing them on the evenings, and they cover then the weekend. In terms of long-term career sustainability, this actually is great, because one of the really hard things about being a hospitalist is being 50 some odd years old and working half the weekends.
Right.
It just doesn't work. These doctors are working 1 in 5 weekends. This is a totally lifestyle sustainable job. And we've gotten great people to do it, and honestly, more applicants than we can hire. So I do believe we can find people who will do that. It is not a job for everyone. It does not need to be. Maybe 5–10% of internists did this. We'd have all we need.
Okay, so then let's get to the economics and the payment of it, because, all right, so you've got a panel of 200 patients that are in and out of the hospital, and you're needing to see them relatively frequently just because of the acuity that's out there. You can bill a little bit higher on the fees schedule, at least on the outpatient, because they're
complex.
They're complex patients. So with that, without your incentive that's in here, without the constraints about your proportion of inpatient, outpatient, does this break even at the University of Chicago or not?
The way I would say is I don't think we lose a lot more money than our primary care loses money, but our primary care loses money.
But I want to solve for that.
Okay. But if I go to my dean and say I want to expand primary care, he's going to
I'm not worried about your dean. I'm worried about the United States of America and the fact that we're just completely screwed right now.
Unfortunately, the decisions they make influence the United States of America. But yes, we think we're probably maybe slightly less productive in RVUs than the typical person who does, but it's not a huge difference, and we're still learning how to do this and getting better at it. But there is, as I said, there's the transition part of it. That's a very important part of it as well. And probably, there's added coordination time and things like that, taking care of these patients. So.
Are you doing transition of care codes right now?
We're trying. It's as people know, it's not hard. Easy. I mean, I track it every week, and we encourage. We're doing the best we can. But I mean, my dean's not looking at this as a cash cow in and of itself. I promise you that. And I think that getting other places to do it, this incentive would make a meaningful difference.
So I mean, I'm trying to get to the point I was making earlier, which is if we want this to be sustainable, it ought to be sustainable, not cross-subsidization or anything else necessarily. So with a panel size, because this is great model of care, with a panel size of 150, which is what we've done, to 250, with a group size of 5 on call, which means there's a certain size of community that this would have to be to do that. But so it may not be the rural, but for many communities it would be. If you're charging E&M codes, figure out or not to do transition of care codes, you're still not going to break even on it. So with $40 added to that as your juicy incentive, does that take care of it or not?
We think it makes a big difference. So if you take 200, patients and it's about $500 a year, it's like $100,000. That's a pretty decent piece of a doctor's salary. I think it fills the hole, and that assumes the maximum, right? In reality, it's going to be more like 25 because it's going to be this mix of the $40 for the newly inactive people and the $10 for the people who haven't been hospitalized. And we've done this at one place. We need to do this at many more places. That's the point of sort of trying to get it out to the PTAC and get it in CMS's hand and do a demonstration project and figure out how to do it in various places.
So you mentioned Clay Christensen, and he's also, within the context of channeling Clay Christensen right now. The other thing is to think about lower cost of care settings. So are you adding home visits and home care directly? Are you making the house calls as opposed to making them come into that expensive clinic?
Absolutely, yeah.
Okay.
We have one of our
So
five.
you got those codes in there right now, too?
Absolutely. One of our five
All right.
doctors does home visits. We're adding an APN capability to try to make that a little more cost-effective.
Okay.
You know, it's always challenging to do things at small scale.
So your hospital, there's not a disincentive to do this? Because that's
They're
the
letting us
final
do it.
issue, is I think the hospitalist program, part of the reason they developed is in a DRG-based system. There is a lot of reasons based on volume and that for the hospitals disincentive to basically do continuity of care. So do you think that this particular type of funding takes care of the hospital disincentive for this or not?
I mean, again, I don't 100% know.
Okay.
Okay, I mean, we know one hospital, I mean, that's the reason to do a demonstration project, to see it in different places. It seems plausible to us. You know, we tried to present some numbers. If the savings are what we think they are in the ACO environment, that should really help too. But
you don't have those numbers.
You know,
Okay.
it's impossible to know.
Okay.
You know, I mean, we think it's credible.
Thank you. I wish you were in the South. I'd probably join your practice.
Vanderbilt.
You had a
Yeah,
comment
just
with
on this
Grace,
point,
and then-
sorry, Ron, I just wanted to say that you spoke very quickly and about a point that I think just for clarification for people listening, you said the addition to the doctor, the $100,000 to addition to the doctor's salary. Actually, the payment is support the doctor and the doctor's practice. Okay. Doctors take home about half of what, on average, they take home. So I just wanted to clarify that because a lot of people might not know.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.